Um, and yeah, we'll have some Q&A as well, and we'll also have a look at how the center has kind of adapted to the pandemic situation in the last year now. First of all, it would be really nice if you introduce yourselves in the chat box. There's there's 18 of you today, so that's really nice. So yeah, just feel free to put something in the chat and say who you are and where you work. I'm also going to just start a little poll, just 1 minute, kind of a couple of questions, just where you're based and what sector you work in. So that's just like to see who's here and have a better idea. So if you can just, it should appear on your screen now. And if you just answer those questions, and then we can have a short look at that can inform our discussion. And the other thing to note is that this session today is recorded. The recording will only be available for 1 week after this, but there is another similar session in June if you want to recommend it to some colleagues or something afterwards. So I'll share the link afterwards. And yeah, if you can just keep yourself on mute for now, while you're not talking, just for background noise, and that's pretty much it in terms of housekeeping. Okay, so I think everybody has now answered the poll, so I'm just gonna share the result very quickly. All right, so a few people from London, others from the rest of England, and you've got all right, that's quite a varied kind of audience today. I don't know if you can see, Dan, the results now. So that's helpful to kind of, to know for the rest of the discussion. Thank you very much, everyone, for answering that poll. All right, Dan, so I will hand over to you now, and I actually have to do something about the slides very quickly, but yeah, feel free to start, and the slide will appear in a minute.
Great, and it's great to have some familiar faces in the group who are with us today as well. That's really fantastic. Good to see you, Alex. Hope that things are going well with the powerhouse down in Poole. Lovely to have you here. Yeah, good. Also recognize other names as well, so that's really, really good to have people here today. Great. Shall I start now, Berenice?
Go for it.
So yeah, let's start with Bromley by Bow's beginnings. You know, Bromley by Bow started in a time of great adversity, really. It's the mid-1980s, black and white photo there, top right. This was really, I was looking at the statistics actually, you know, this was at the time of that sort of great transformation of the UK and sort of economic model. And it was a time of significant convulsion for the East End community, where we're based in Tower Hamlets in East London. And it was really, you know, very, very challenging circumstances that gave birth to Bromley by Bow. And it's probably worth reflecting on that a little bit as we go forwards, really talking today as well. So that black and white photo top right, in the very sort of right-hand corner of that photo, in fact, you see the back of an East End church, and in the foreground, a pretty scrappy and ill-cared for local authority park. And the story of Bromley by Bow is the story of a priest who arrived there in 1984 to encounter a small and very old congregation and a few £100s in the bank. The transformation of Bromley by Bow over the last 35 years has been quite remarkable. And we think that there are really important understandings and learning to be done from that can help to shape the development of provision within communities across the UK and indeed further afield as well. It's probably worth pointing out that the knowledge exchange program that Berenice manages in the last 8 years has hosted something in the region of 10,000 people who have physically come to Bromley by Bow up until COVID at this time last year, running at about the rate of 1,500 people per year, visiting Bromley by Bow on our study program to understand the Bromley by Bow model. And that's, included many leading health systems developers, including people like the Minister for Health for Singapore, the Minister for Public Health for Thailand, and people from all around the world, as well as, of course, the UK and particularly Western Europe as well. And coming to understand the Bromley by Bow model in a way of thinking about how we might support the development of more connected communities, more enabled and capable communities, and healthier and happier communities as well. So from that picture of 1984, really interestingly, Andrew, who's this young priest who arrived at Bromley by Bow, started to work with the community to open up the church to the local community and to invite people into fairly extensive and crumbling church buildings to set up arts workshops and arts studios. A community nursery was run from within the church itself, the very place where worship took place on a Sunday. A gardening program, a program for local people with disabilities, a small community cafe, and so on and so forth. And the beginnings, if you like, of a fairly small and locally developed community hub. In all of this, there was some fairly spectacular failure of primary care in our community, and Bromley by Bow reflected on this and thought that our community deserved something better. And we said that we had an aspiration to develop primary care at Bromley by Bow, to build a health centre. Really interestingly and curiously at that point, the greatest obstacle that we faced was the National Health Service, that never actually heard of communities building their own health centres before. Undoubtedly, the NHS thought that that was a job for the doctors or for the health system itself, but certainly not for community organisations. It was only really when Andrew Mawson managed to get Brian Mulwiney, the then Minister for Health, down to visit Bromley by Bow, that Brian Mulwiney instructed the local health chiefs to talk to us about the idea of Bromley by Bow building a health centre as part of this kind of community hub that was later to become the first in the national programme of healthy living centres that were established across England. Eventually about 350 healthy living centres were developed, and Bromley by Bow was one of the, I think, the first and one of the flagships. Today we're a much larger organisation. The charity itself supports about, well, I think last year actually it was slightly more than this, it was about 10,000 or 11,000 people, local people. And our GPs who came to become the GPs in the health centre that the community charity built now manage 4 GP practices and have about 40,000 registered patients. So, and we are the principal GP practices in one primary care network. So we're supporting the development of the thinking around primary care and primary care networks. And of course, a critical part of the Bromley by Bow model when we established the Healthy Living Centre, which was in 1997, was the idea of social prescribing, of clinicians having more holistic consultations with patients, understanding the broader needs within the patient's lives and referring them to social prescribing. And so we've been effectively developing social prescribing for over 20 years at Bromley by Bow, and supported the rollout now by NHS England nationally in the last few years. If we move on to the next slide, please, Berenice. So Bromley by Bow's done a lot of thinking. I guess one of the hallmarks of Bromley by Bow over its 35-year history now is it's a very reflective organisation. It does a lot of thinking, it carries out research, evaluation and so on. And it's continually, if you like, reflecting on its model and how its model is flexing and evolving and developing in order to respond to community needs and to respond to our own learning. And one of those pieces of reflection and learning has been around kind of exactly what kind of an organization we are, and what some of the principles behind us are. So we're community owned. Accessibility is probably one of our critical issues around how to make services within communities accessible to communities, particularly to those who are perhaps least likely to come forward and access services usually. Having the hallmarks of being a very welcoming space, and then the range of provision that we have available all within one campus is really, really important. So we somewhat liken ourselves to a community department store. And Berenice, if we go on to the next slide, please. So a community hub, the community charity, medical practice, and as I've mentioned before, a team, it's the team that I'm in at Bromley by Bow called Bromley by Bow Insights, which carries out research and evaluation, seeks to support others to learn from Bromley by Bow. And of course, in doing that, that requires us to kind of theorize and reflect on ourselves and how we talk about ourselves and how we understand ourselves so that we can support others to learn from Bromley by Bow. But equally, as Berenice mentioned, we're also very interested in learning from other models in the UK and indeed across the world as well. We recently held an exchange visit, virtual exchange visit with a health system in Sweden, for example. And a couple of years ago, we had a whole group of folk from South Central Alaska from the Nuka health system visit and spend a day at Bromley by Bow and exchanging ideas from their wonderfully influential and important health system in South Central Alaska, and similarly us sharing our learning from Bromley by Bow. So we continually wanting to learn from and exchange with others as well. If we move on to the next slide, please. So this is this is a slide that certainly talks to the clinicians who visit Bromley by Bow and those who are interested in social prescribing, but equally those who are interested in community development as well. And we're very, very, you know, the NHS is this, what do we say, it's the closest thing we have to a national religion or something like that. And it is obviously very dear to the hearts of the public in Britain and so on. But there's this strange correlation in people's minds between the National Health Service and health. And whilst the NHS is a wonderful institution, it is, of course, very, very focused on treating illness rather than on creating health. And we think we need to rebalance this equation. So we've created this slightly provocative diagram, which is to suggest that, you know, these terms, you know, secondary care in NHS parlance means hospitals, and primary care means general practice, dentistry and opticians, and pharmacy. We would like to suggest that primary care should be redefined as the way people look after their own health. Secondary care might be defined as the way people look after their own health alongside them with their interactions with family and friends. And tertiary care might be the two rungs below, plus what's available and the support and the mutual support and so on that people get from within their communities. And that, of course, includes things like, you know, how do we design our communities to become healthy communities? How do we make cycle-friendly and walking-friendly communities? How do we provide green space for play and recreation within our communities? How do we provide healthy food options within our communities, and so on and so forth? And finally, of course, at the top of this pyramid is the NHS. Should all else fail, as it were, and should we need, you know, and as is, you know, rightfully pointed out, at the point where we become ill, of course, we do need a health system that will tackle illness, and that's of course what the NHS does. But also, I think in all of this is a rebalancing, therefore, of what the NHS does. I don't know if you know this, but currently the NHS spends, I think, something like 96% of its budget treating people who are already ill, and something like 4 or 5% on health prevention and supporting people to stay well. We think we need a rebalancing of that budget, and we need to get into a more preventative space, and we need to get into a space that works more with community around health creation. So that's, in a sense, what this diagram is asking us to think about, really. If we go on to the next slide, please. So that's an aerial view of Bromley by Bow. The church still there, top right-hand corner. we've now built a fairly extensive community centre, and we built a health centre as well. And at the same time, we persuaded the local authority to gift us that rather scrappy and ill-cared for pocket park. It's a 3-acre park, to give it to Bromley by Bow to manage for 30 years, at which point we set about kind of tearing up the concrete and completely re-landscaping the park. The site has multiple ways in and multiple ways out. It's very porous, it's deliberately so. Lots of beautiful courtyards and pergolas and beautiful park planting and sculpture, and flower gardens and allotment gardens and so on and so forth. And primary care is very much sits in the middle of all of this. The church is still a church on a Sunday morning, but it's used for many other functions during the week. We have a lovely community cafe serving economically priced and healthy food. We have an internet cafe that people can use freely. We have welfare advice. We have arts programs. We have community choirs. We have theatre with the National Theatre as well. We do a lot of work around employability and skills. We have a social care provision. It was one of our first statutorily funded programs well over 30 years ago now. So working with people with learning disabilities and physical disabilities through our arts program, actually, very interestingly. We have a whole training program as well at Bromley by Bow. We do a lot of community outreach. We have a great community development program called Communities Driving Change, which works on local housing estates, and so on and so forth. So we also have very, very high quality clinical care as well. Excuse me. The Bromley by Bow Health Partnership and Tower Hamlets Health is amongst the highest scoring general practice and health systems around, for instance, sort of blood pressure and cholesterol and so on. So we have, you know, a really, really high scoring clinical health provision as well. So, but the whole point is the interaction at Bromley by Bow between all of these programs and the professionals who work within them. Going back to that department store analogy, the professionals working within Bromley by Bow, whether you're a GP or a nurse, or you're a welfare advisor, or you're an artist, or you're working in our community outreach teams, you're all part of one team. And this is really, really critical, that people understand that it's the integration, it's the collaboration between teams, it's the, to use that phrase, it's the boundary spanning that you do across different disciplines and silos that would not normally connect. That is one of the absolute hallmarks of Bromley by Bow, actually. And it's by getting professionals of very distinct professional disciplines working together, designing projects together, developing programs together, that you get the really kind of creative innovation happening as well. So we do a lot of joint working across teams at Bromley by Bow and mixing people up, and a lot of kind of creative thinking and a lot of innovation that is born and co-production with our community, of course, as well. So it's a very exciting and creative organisation, and we're continually developing new ideas and new programs and new projects, not least, of course, over the last 12 months because of COVID, and we'll talk about that in a little bit going forwards. So those are some photos of Bromley by Bow, and there you can see the park on the bottom left, a wonderful intergenerational afternoon tea party, designed actually and worked with one of our arts groups, our disability arts groups, with artists. And that involved sort of no end of fun and egg and spoon races and all sorts of things that kind of brought in some exercise as well, but lots of fun as well. And as I say, and part of Bromley by Bow is around the aesthetics and around the design, making the place feel interesting. It's very non-institutional, deliberately. There's very little signage at Bromley by Bow. There are no NHS signs whatsoever at Bromley by Bow. It's about being a community centre and making people feel that it's a centre that they can contribute to as much as receive and gain support from. There's a tea party, a dinner run by our time bank. So we have Flourishing Time Bank at Bromley by Bow. And that was one of the sort of, our time bank was a bit like University of the Third Age. So lots of group activities as well as individual exchanges. Top left there, we have one of our arts programs in the ceramic studios. We have a ceramic studio, stone carving studio, stained glass studio as well at Bromley by Bow. And those are some of the gardeners in the bottom right. And the top right, we have the connection zone, which is one of the entrances to Bromley by Bow, where we have free use of computers and telephones and printers. And we have welfare advisors and so on available, and a series of sort of small one-to-one interview rooms where people can get more confidential advice as well. If we go on to the next slide, please. So we've done some interesting work thinking about values at Bromley by Bow. And these are the 4 values that we came up with. We call them active values. And one of the reasons that we selected this set of values was, well, a lot about speaking to our humanity as an organization that works with our community. And it really speaks to this idea of kind of co-productive relationships, about community empowerment, about really rethinking the relationship between organizations and the communities that they're based in, and between the professionals and the members of the community that they work with as well. So these are not the kind of values that you would normally find for an organization, which tends to speak of things like integrity and so on. But this is really about the kind of values that our staff and volunteers can really live through their daily workings as on site and across the neighborhoods that are near to us, around kind of really having a relationship of equals with our community. And that last one, assume it's possible, is really, that's been a long-term strapline for Bromley by Bow. And it really speaks to this idea of tearing up the mold and creating a new way of working. I'm always reminded of that one of Einstein's law of insanity, really, which is that you expect to go on doing the same thing again and again, but somehow hope that one day you will achieve some different sets of results. And I think this is the challenge to all sorts of systems within the UK, particularly those that are working with deprived communities, which is if we don't start to think about doing things radically differently, we will go on living with long-term deprivation and disempowerment within our communities for a long time to come. So part of this is about having the courage to assume it's possible and to assume that something different is possible, and that communities have the wisdom to create that difference. Okay, Berenice, let's move on to the next slide. So Public Health England is very, very interested in Bromley by Bow, to the extent actually that over the last few years, Public Health England has funded a whole research programme at Bromley by Bow to understand the Bromley by Bow model. And the reports are on our website. You can download them and read them. There's a summary report and a full report. So this is the distillation of part of that report, which is looking at the principles of the Bromley by Bow model. And I've already mentioned much of this on the previous slides, but it was built by and with the community. It doesn't just meet needs, it's also about opportunity. Man or woman doesn't live by bread alone. We need theatre, we need opera, we need mosaics, we need pottery, we need gardening, we need wonderful evening banquets. We need a rich cultural and social life as well to go along with some of the other critical things, such as welfare advice and financial capability and support with utility arrears and getting a job and a qualification, all those other things as well. So it's very much around opportunity as much as needs. The permanence of Bromley by Bow, well, it was built on the foundations, if you like, of a church that had been there for well over 100 years. As a community centre and a healthy living centre, it's now been there for 35 years. So these permanent features within our communities are really, really important, these long-term features. Creativity and fun. So, I think it's really interesting thinking about this, that the kind of experience of going into work in the morning has to be as interesting and as fun for our staff and as creative for our staff as it does for our clients. We have to think of this as co-production. If we trot into work every morning, whether we live on the housing estate nearby or a few miles away, If we're not looking forward to a day of fun and creativity, just as much as our community might when they arrive at Bromley by Bow, then we're really doing the wrong thing. So it has to be interesting, it has to be about learning, and that's true for our clinicians as much as our welfare advisors, as much as our arts teams. Connection is probably the most critical thing of all of the things that we're doing, is building connection between ourselves and the community, between community and community. Connection and connectivity in a very disconnected modern world is absolutely critical. And there's something very special about the role of the third sector that is a kind of boundary spanning by in its DNA practically. So, it sits in the middle between a whole series of other interventions, including a lot of silos that don't always talk to each other, local authorities and health authorities and all sorts of other things that don't necessarily connect. And Bromley by Bow and the voluntary sector in general is very good at helping things to connect. Okay, next slide, please, Berenice. So one of the things that we did as part of this 2-year research at Bromley by Bow was to begin a very, very significant program of community research. This is employing local residents as researchers and training them. And then this led to a whole program of understanding what's meaningful and what matters to our community. And this has led to some really, really groundbreaking work around creating an outcomes framework for Bromley by Bow, which we've spent a couple of years working it up now, and we're just about to start to apply this full scale at Bromley by Bow, having gone through the piloting and so on, which is to establish an outcomes framework that's been devised by our community based on what matters to our community. And it would seem really interesting to think about this and reflect on this for a second, that, when the state spends, effectively taxpayers' money on providing services to its communities, as it does, the state, the NHS, local authorities, national government, etc., etc., etc. Does anybody stop for a second to ask themselves what matters to those communities and how might we measure the success of what we're doing in the terms of how that community defines what matters to it? And it would seem that this is really kind of, both on one hand, incredibly simple and really quite an obvious thing to do, but actually appears to be our attempts to do this at Bromley by Bow have really revealed that actually it's a very, very uncommon thing to do for people who provide services to communities to ask those same communities, how should we be measuring the success of this program? So these are the outcomes: building people's capability and resources, ensuring people have their basic needs met, which very much speaks to sort of Maslow's hierarchy of needs, creating knowledge and skills and opportunity for people, allowing people to contribute. So this is very much around co-production, around bringing the community in as creators of the solution to the issues that a community may face. And this is absolutely critical. And building, as I've mentioned before, building people's connection to others, but also building people's connection and sense of identity in terms of a place and a community, which of course, in a very, very modern and fast moving city like London, is a continual challenge, actually. We have a kind of quite a mobile population. Literally a third of our borough's population of 350,000 people moves in or out of the borough every single year. So it's a community that is, certainly some parts of that community are tremendously transient, actually. If we move on to the next slide, please, Berenice. So that's a picture of, that would have been Tower Hamlets pre-COVID, of course. That's a sort of street scene in Whitechapel, just about a mile away from Bromley by Bow. Of course, it hasn't looked like that for a year now, but hopefully it will be coming back to that over the summer. But that kind of gives you an idea of what the bustling, vibrant city and borough of Tower Hamlets looks like. Yeah. Okay, next slide, please.
Thanks, Dan. And we're actually moving on to little virtual tour of the centre.
Right.
We'll come back to COVID-specific kind of adaptation just after a couple of videos. So I am going to share the video now, and Dan can walk you all through the center as if we were there. Also, just to note that if you have any questions at any point, just type them in the chat box. I am keeping an eye and making notes, so feel free to share any questions there. Okay.
Great. So if you'd arrived at Bromley by Bow this morning, you'd have been walking through that arch, which those who spotted it was stuck actually to the back of the church prior to our development. Then you walk into this wonderful courtyard, which interestingly our architect talked about. Courtyards are normally in the middle of buildings, and he created a courtyard that was part of the entrance. This is very much a calming, tranquil, serene space that you walk into that invites you to sit down at the table and chairs and have a coffee or pull out your phone and check your messages from your friends. Or it could be used for an art activity for our Young at Art, Older Arts group, which grew out of our leg ulcer clinic, very interestingly. There we are, summer and winter, and right now we're not quite sure whether we're in summer or winter, are we? It snowed last week. There's the entrance to Bromley by Bow. So you're walking into the entrance to a health centre with no NHS signage through this lovely glazed entrance area. So there's interesting transitions of space at Bromley by Bow from the inside and the outside, and these two are both working together really critically. There we are, you see again, looking into the health centre waiting area. And there again, planting, pergolas, walkways, courtyards. That's the health centre reception area. The seating's been designed. There's art on the walls rather than tatty posters. The seating's been designed so that people acknowledge each other rather than sitting in rows. And there's some more of the health centre. You're literally sitting in the waiting room and you're looking out through what's effectively a greenhouse there. A social prescribing pop-up banner there on the left. And then you're coming into now, what I think this must have been during COVID that we filmed this with the things on the chairs. But we're walking into a group room there, which is really interesting. And we think the future of primary care is going to be a lot about group work. This is the church. So the church has last few years not been a nursery, but it's actually where we do a lot of our interactive activities around exhibitions, for example. This was part of our community research program at the time. There was the church for about 30 years. It was a nursery, as you can see, and a very interesting nursery with everybody's children going to it. That's one of our knowledge share events happening in the church. So that could have been you this morning sitting there in the church. That's Emma from our population health team talking, and Ian Jackson in the foreground, who's the director of our health partnership, with his back to us there. And that's a group coming to visit Bromley by Bow. And hopefully one day you'll be able to come and visit again to Bromley by Bow. These are some of our nurses actually talking to a group from the Netherlands. That's the church today. So the food bank moved into the church in May from a neighbouring church. That's because the numbers went up from about 150 families a week to about 1,000 families a week. So the food store now takes place in the church, and the food bank is run through the church on a Monday with, as I say, probably about 1,000 people every week collecting food on behalf of them and their children. That's a picture of the church. The church took a direct hit in the Second World War, which is why it doesn't look like an old Victorian church. It was rebuilt in the 1950s, having been destroyed in the Blitz. And there we are. So lots of opportunities to sit and chat at Bromley by Bow, lots of benches in the park. There's a view from the park looking back on the health centre on the right and the community centre on the left there. That elevation of the community centre is based on the Doge's Palace in Venice. Interestingly, we have a wonderful architect who's, there we are, community fairs. So the park acts a bit like the village green, if you like. And you know, the village green, the cafe, the GP practice, the church, all there, a bit like a sort of typical English village. But that's a summer fair on the church, on the green at Bromley by Bow. There's another photo of the summer fair as well. And we celebrate the whole set of faith calendars. So that might actually have been an Eid party, I think. There's that intergenerational tea party again. There's the cafe. This was our time bank running in the cafe. So time bank did lots of meetups, weekly meetups in the cafe for people who wanted to join the time bank or find out what activities were on that week. So face to face, that was part of it. That's Flo, and she was one of the cooks in our cafe at one point. There's the cafe. So, you know, really, you know, beautiful cafe. Those tables were actually made by local people. And the rings on those tables are broken plates that were dug up when we did the park. So there are lots of broken crockery in the park that we used to make those mosaic tabletops with local people. And so, yeah, kind of creating opportunities for that sense of local ownership as well. And the cafe looks out over the park. So the cafe is very much the central hub of the building. There's our connection zone again. And one thing to say in our cafe, you know, our GPs will be having lunch in our cafe after morning surgery. And of course, you know, there are their patients having lunch at other tables in the cafe as well. So something about breaking down the barriers and the kind of the mystique of professionals and community is also really important. But that's the connection zone there, where you come in and find out what activities are on, free use of computers, as I say, and printers and phones to make phone calls if you need to. That's our connection zone team, as I say, who are, you know, not sitting behind a desk, but they're roving within the space and helping people and so on. And we have drop-in welfare advice several mornings a week, for example. There's our community fridge, and as you can see, it's full of cantaloupe melons. So we have a community fridge as well as the food bank on site as well. So the community fridge supports the distribution of surplus food. There's our ceramic studio again with our art activity. I think that's probably for one of our disability groups actually. So that has lots of volunteer helpers as well. So there's an opportunity for volunteer helpers to both learn how to work and a whole training program around social care as well. There's one of our digital teaching spaces as well, which teaches both digital inclusion and other subjects as well. And of course, digital inclusion became a critical issue under COVID as well, in supporting the community to become more digitally enabled. And we'll talk about that in a second and there's another view across the park and back towards the community centre as well. And there's the view in the opposite direction. So using pergolas to link the buildings. And Bromley by Bow is a collection of buildings that have been built over a period of years. So there's lots of movement of staff and community backwards and forwards from one building to another across the park. The park's a very animated space actually, which is, you know, whenever you sit in the park, there's lots of activity going on, including local people coming to garden, as you can see here in the foreground. So yeah, creating this active space is really, really interesting, I think, and creating the visibility of the activity from the outside. And there's this glorious scene. This is right from the opposite end of the park, actually, looking backwards. And there's a couple of our gardeners in the park as well, who actually became a couple through their engagement at Bromley by Bow. Yeah.
Should we buy them?
Right. Great.
Great, thank you. I hope that kind of gave you a little bit of an overview of what the centre would look like with people. So not at the moment, but hopefully very soon, and hopefully one day you can all come and visit as well. And what we're going to do now, we're just going to show you a short video about social determinants of health. That's presented by one of our GP partners, who is Saul Marmot. And so this is just a little introduction. There's a longer video about this that's available as well. We can share the link with you, but this is just a few minutes because obviously social determinants of health are such an important principle in terms of our work at Bromley by Bow. So let me just share that with you now. There you go.
I'm Saul Marmot. I'm one of the GPs who works with the Bromley by Bow Health Partnership. We work in very close relations with the Bromley by Bow Centre. In fact, one of our surgeries, Bromley by Bow Centre site. This is really how our relationship started. I've been lucky enough to be here for over 20 years now. You know, I've had some wonderful experiences and learned an awful lot. Essentially today I've been asked to talk to you about the social determinants of health. Now this is an expression that's been around for a while now. Unfortunately, I'm going to have to condense decades of research into a few minutes of presentation, so I hope it makes sense. And I hope that you can bear with me and bear with my appalling technology skills as I get it wrong. If I get anything wrong, please just bear with me. Okay, so what are the social determinants of health? Essentially, it's the interaction between your environment and your health. So it's how your environment affects your long-term health outcomes, and it's how your health affects your long-term environment. So, if you're sick and you're poor and you haven't got the personal resource, the access to information, the ability, the belief that you can make a positive difference to your health outcomes, obviously that has a massive effect on your mental health too. Your mental health then deteriorates, as does your physical health, because obviously they work in a cycle. You know, the more depressed, the more anxious you are, the less likely you are to be able to recover from your physical health, and the less likely you are to be able to access those resources that might help you. So obviously, all of these things have an effect on the next generation. They have an effect on the next generation, which means that then the next generation starts again at the beginning, where we started with Kid A and Kid D, and these inequalities do get perpetuated. So the slide I've got up here just as some headlines. These are the main areas of the social determinants of health. So you've probably seen countless slides like this. There are so many different ones and they all say slightly different things. Importantly, one of the social determinants of health is your economic situation. So the economic situation of you and your family, but also the economic situation of your community. Have you got access to healthy food? Have you got access to good education? What's the expectation of your school? What's the expectation of your parents? Will they be able to push you? Will you be able to achieve? And of course, the environment that you live in. So the house that you particularly live in, is it damp? Does it have a garden? Is it overcrowded? Is it a lovely house that, you know, there's plenty of freedom and space in? Do you have access to open spaces? What about work? Do you actually have work? Are you in work? If you are in work, what's the work environment like? And healthcare. So we're very fortunate, as I said, to have access to good healthcare in this country. Much more fortunate than lots of places across the world, but there is still a massive difference in what you can and can't afford just because of your social class. So here's my summary slide. Your health is about three things. It's about your physical health, it's about your mental health, and it's about your social health. And if all three of those things are in balance, then that will make a massive difference to your overall health. If all those things are in balance, then hopefully your next generation will be able to progress and to deal with the things that it's thrown at it, sorry. So that in a nutshell is the social determinants of health. I'd normally take questions at this time, but quite obviously that is not going to happen. So I hope it's been informative. I hope it's been at the right level, and thank you for bearing with me with the absolutely appalling IT skills. Hopefully we'll see you again sometime. Bye.
All right, so we're now going to move on to the part about how the centre has been adapting in the last year, how services have changed and the way we interact with our community has changed as well. So Dan, I'm just going to share the next slides now and I'll hand over back to you.
Great. And obviously when COVID struck, this literally this time last year, it was, for an organization that is so rooted within its community, and so based on kind of physical contact with the community and its physical interaction with the community. This is, and including general practice, of course. This was an incredible shock to us, and we had to very, very quickly shift our provision online. General practice saw a very significant, across the country, saw a very, very significant reduction in people wanting to access primary care, at least initially, certainly. And then, of course, it was all around building virtual consultations with patients and trying to improve what's on websites. That was a very, very critical thing as well. So we significantly invested in our website and invested in making it as accessible as possible and as clear as possible, and providing telephone numbers for people to access us, for example, was really, really critically important at that stage. Working in partnership with other organizations became really critical, so that we could ensure that those referral pathways were there. Because if everybody was trying to reach people individually through remote means, it was very important that we also had the connectivity between ourselves, and that we understood what other people were doing and they understood what we were doing, in order for us to be able to cross-refer clients as well. And then we took a whole range of our programs and provisions online. So our social prescribing program became, just as it did across the whole country, became around social prescribing link workers working with clients who've been referred to them, or indeed existing clients that they were already working with them on the telephone or by video sessions with people, and then helping them in turn to support services, again, many of which were now online rather than physical as well. So that became really, really, really critical. We massively increased our social prescribing team over this period of time. We've now got 7 full-time link workers at Bromley by Bow. So that team has grown enormously under COVID. And we've got social prescribing link workers within general practice, employed by general practice, and within the charity, employed by the charity, but they work together as one team. And we've incorporated a mental health specialist social prescribing link worker within that team as well. So that's been critically important. Welfare advice, so we've done welfare advice online, helped people to make claims online, get good advice online, supported people to upload photos and scans of documents that they've needed to online, and all that sort of thing as well. We've continued to do our adult learning provision and employability program online, and that's included a massive increase in terms of supporting people around digital access and digital inclusion. So very, very significant numbers of people going through computer training and so on. And we've also distributed devices to people who haven't had devices as well. We've continued to work with, we've supported a whole network of social enterprises over the last decade, probably about 50 social enterprises that are running in East London at the moment, maybe more, supported through our enterprise incubation program. And we worked very, very closely with them for them to survive both the economic shock of COVID, but also how they could continue to run their social enterprises that provide benefit to our community through this period as well. So that's been really, really important. We've done social care in people's homes. So we have a whole social care program of people coming into Bromley by Bow normally. We took that whole program and supported people through social care in their homes. We work very closely with a partner organisation to provide bereavement counselling through this period as well, and so on. We've run lots of arts activities online. We've run a whole series of photography courses and photography groups online, and put up exhibitions online, and made films online with people who've never actually met, where everybody's filming individually and then editing it to create one film together, teaching people who've never made a film before how to make a film, how to edit a film, how to put a film together, all online as well. So it's been a tremendously interesting program. I teach on our social prescribing link worker training program, for example, and last April we were part way through teaching a cohort of link workers in Newcastle, and we were previously going up and down to Newcastle to teach them, and we put that whole program online, and we've now engaged 3 new cohorts of social prescribing link workers on our training program since then, that have been entirely online courses, which, it has to be said, and Berenice has moved the whole knowledge share program online as well. And whilst undoubtedly, and I think this is, there is a total recognition that the online experience is by no means the same as the face-to-face experience for many of these things. Nonetheless, it certainly has other benefits to it, and one of them is reach. We are able now to do, for example, online training programs to people who may be geographically distributed across the UK, who could never really come together in a classroom to learn, but can learn together online, for example. So it has been a tremendously interesting experience. As I say, we moved the food bank into Bromley by Bow from a neighbouring church that didn't have as much room as we have in May. That's been really helpful in terms of us connecting with, as I say, about 1,000 households, 1,000 families every week who are coming to collect emergency food. One of the other programs that we brought back physically as soon as possible was welfare advice, which, while some of it can undoubtedly be done remotely, for many of our community, for those with poor, sort of low digital skills, or potentially without very much data or the right devices, or for whom English is a second language, or with low levels of literacy, interfacing with very, very complex online welfare systems, including scanning and uploading documents and so on, is a real challenge for quite a lot of our community. So I think that we brought back welfare advice face-to-face in COVID safe conditions very early on, and we've continued to do that, and that's been one of the most challenging services for our community in terms of, and most critical as well. Okay, if we go on to the next slide, please, Berenice. So we've done a lot of learning through this COVID period. I think all organisations that I've spoken to have as well. And we've used, one of the interesting features is we use primary care data extensively to identify people at risk. And through the expansion of social prescribing, have actually reached many, many, many more people than we would have previously as well. Supporting people to support themselves, and kind of that asset-based way of working has been absolutely critical, and getting family members to support each other and helping family members to support each other has been really, really important as well. We've done a lot of data analysis through this and understanding what's happened to our community, and of course that's also been augmented by a lot of other statistics as well, which I think we're, all of us are very, very acutely aware that social prescribing has really laid open the tremendous levels of socioeconomic inequality in our community, which were prevalent before, have been exacerbated as part of the COVID year. And it's, I think, really shone a lens on sort of inequality, and which is not unhelpful in many respects. I mean, obviously it's a problem we'd rather not have, but this intense focus on inequality, I think, will be helpful in trying to mobilize communities and resources around that in the future. If we go on to the next slide, please. We've also done massive amounts of increased outreach, and that's been really, really critical for continuing to reach community. And I think that will be critical going forwards. We're likely to go through quite a considerable period now of real challenge for our community. We'll be part lockdown, part not lockdown for a while to come. We've no idea what may happen in terms of subsequent waves of potentially of COVID and variants of COVID, but also what's happened to our community as well in terms of anxiety, in terms of social disconnection and so on. So really starting to think about how we tailor our programs for that kind of context going forwards is really, really critical. So this has led to a lot of thinking about that. Yeah, if we go on to the next slide, please. So we're doing that thinking as we speak. We are gearing up for being able to do outreach. We hope that the conditions will allow us to do a lot of community engagement as the weather gets better as well. And depending on how things open up, potentially the ability to run either small scale or larger scale events in the future, in the summer, both in our park, but also on neighbouring housing estates. We think there's going to be a whole process needed around rebuilding community and rebuilding relationships, and that's a critical area of our focus. But there are other areas of our focus as well. One real level of concern is around children and young people and what's happened to them under COVID. And I don't know if people saw the headline in the newspaper, I think it was yesterday, but 40% of our BAME young people are currently unemployed in London. This is a real social issue, and one that we know is incredibly scarring for life. If you come into the labour market at a moment like this and then remain unemployed for a number of years, it has effectively lifetime consequences. So there's a lot of work that we want to do around that as well. But there are other areas as well. Around mental health, for example, is another critical area of support for our community going forwards. Great. I think we may have come to the end. Yeah.
We have. Great. Thank you very much, Dan. So now it's time for a little bit of discussion and kind of a Q&A. So please feel free to kind of unmute yourself and come on if you want to. I can see Maureen has unmuted herself. So if you have any questions, feel free to ask away. And if you're shy or you can't speak right now, you can type it up in the chat box. That's also fine. All right, Maureen, do you have a question?
Sorry, I was just unmuting myself in preparation, but I haven't got a question just yet.
That's all right. Does anyone else have any questions? I know we also have questions from before the event during your registration form. So if people are too shy right now, we can start with that. But otherwise, feel free to ask away. I know it's always a little bit difficult to speak first. Okay, so we might start with a pre-event question, Dan, if you don't mind. So there was a question about how was the development funded and how is ongoing operation funded?
Yeah, sure. So when we kind of moved from being a dilapidated church to building a healthy living centre, that the funding came through a number of sources. Some of that was grant funding, but also the Bromley by Bow Centre, the charity, to build the health centre, we took out a mortgage of about, I think it was about 800 or 700,000 pounds to build the curved building, the health centre, based on a business model that was predicated on the fact that the NHS would then pay the rent on that building for the GP partners to inhabit that building as a health centre, and there would also be a service charge for the maintenance of that building, an annual service charge as well paid. So that created, if you like, the business proposition for the building of the health centre. But the community centre itself was largely built through grants, yeah.
Thank you.
And then in terms of, ongoing running costs, the centre is a charity. It does extensive fundraising. It has a staff of about 100 staff within the charity itself, delivering the community programs to our community. And so that is, in a sense, revenue funded through ongoing fundraising and the winning of contracts and the winning of tenders to provide services for our community.
I'm just going to keep asking questions until someone raise their hands or unmute themselves. So at any point, please feel free to. Someone is asking, they're looking at opening a new community centre, and they're asking about, they're interested to know about the variety of social prescribing initiative we offer and how those partnerships work. Yeah,
sure. So, of course, we were amongst the forerunners of social prescribing 23 years ago now, when we built the health centre. And the health centre was predicated on this concept of clinicians making referrals to non-clinical services, to the services initially, at least, that the charity was running. That's developed since then, and we've now had link workers at Bromley by Bow for well over a decade, I think. And then, of course, Bromley by Bow was amongst a whole group of people working to get the NHS to adopt social prescribing as national policy. And the NHS adopted social prescribing as national policy about 3 years ago now. And 2 years ago now, the NHS decided to more or less oblige GP practices to join what are called now primary care networks. So every GP practice in England is part of a primary care network. These are usually networks of between 3 and 5 practices, with ideally patient population sizes of between 30 and 50,000 patients. That's in essence now the basic building block of the NHS, is the primary care network, and within that its constituent GP practices. The NHS England then came up with the money for initially 1 social prescribing link worker per primary care network. So in England, there are something like 1,300 primary care networks, and there are now in employment well over 1,300 social prescribing link workers. In some parts of the country, some of the pre-existing social prescribing schemes that existed in some cases long before the NHS adopted social prescribing continued to run in parallel to the NHS social prescribing. But effectively, social prescribing, as is often understood by people now, is seen as an NHS initiative with, as I say, the provision of at least 1 link worker per primary care network. The NHS's own ambitions are that within the next 2 or 3 years, every primary care network should have 3 or 4 link workers, and potentially the idea of specialisms within those link workers. So some link workers might specialize in social prescribing for children and young people. Other link workers might specialize in social prescribing for people with mental health challenges. Maybe even have social prescribing link workers who are trained welfare benefits advisors, who would be a hybrid role of a link worker and a welfare benefits advisor, for example. So this is the development of social prescribing as is within the NHS. The next challenge probably is around the services, i.e. what are the services that these link workers will be referring their clients or patients to? And that is really the next big topic of conversation within the world of social prescribing, is who is funding the services to which the link workers need to refer their patients to. And that's the subject of really kind of very live discussion at the moment about that. At the moment, it has to be said that there is very little commissioning of services specifically to ensure that services are available for those who get referred by link workers. And certainly, I think nowhere in the country, and I'm not sure this would be a good idea either, is there a system of micropayments, of individual small payments being made against individuals who are referred to. You could imagine a gardening group receiving a referral for somebody, and with that person comes a payment of, I don't know, £5 an hour or something like that, or whatever it happens to be. I'm not sure that's the route anyone would want to go down. It's certainly not a route that exists at the moment. I think potentially more feasible is this idea of sort of some block commissioning of services that are likely to meet the needs of those who've been referred by social prescribing. And it has to be said that the Rotherham social prescribing scheme has really pioneered this work. They created a pot of money. This is a long-standing non-NHS funded social prescribing scheme that has existed for about 7 years now. And alongside the money for the link workers came a pot of about £300,000 a year to fund additional third sector services to meet the needs of those who are being socially prescribed by the link workers. And that's probably outstanding in the UK as a model of providing services tailored specifically to those the needs of those who are being socially prescribed. And I think probably it's a very interesting model for us all to hold in sight as we go forwards and thinking about how a service is funded. Yeah.
Thanks, Dan. We've got a couple of questions in the chat. So there's a question from Nikki, who is asking, was there any resistance from the community when social prescribing was first introduced in the health clinics? Since some people might only think treatment as medications / something involved with the hospital.
Yeah, sure. That's a really interesting question. And the truth of the matter is we are by no means there yet in terms of the introduction of social prescribing across the, 7,000 GP practices and 1,300 primary care networks in England is only We're only 2 years into that journey yet, so it's still pretty new. The truth of the matter is that many patients haven't heard of social prescribing and don't understand it. And there are people who would be hesitant even to use the term, feel that actually the term social prescribing is not something you ever want to really mention to patients anyway. That's not true everywhere, but there are some social prescribing schemes who deliberately don't use that term at all in terms of the public. It also has to be said that there are a lot of clinicians, lots of doctors, nurses and healthcare assistants and receptionists and practice managers who don't really understand social prescribing yet at this stage, or don't fully understand it. So there's a journey to travel in terms of clinicians understanding what social prescribing is, also clinicians being given the opportunity to have more holistic consultations with patients, which quite frankly is very difficult in the current constraints of the 10-minute consultation. As we know, GP consultations tend to be very short and they are very clinically focused. That provides little opportunity for the GP to really unearth what the social issues are that are going on in that patient's life and to refer them to a link worker, a social prescribing link worker. And so work needs to be done with the clinical parties around understanding social prescribing, and work needs to be done with the community, maybe not about understanding the term social prescribing, but understanding that there are these fantastic people called link workers who work in the community, who are absolutely brilliant at helping you to tackle some of the challenges going on in your life. I think ideally, eventually, we will get to the point, hopefully, where you don't have to see a GP before you get to see a link worker. There is something slightly absurd with the idea we're trying to reduce demand on GPs. Yet in order to see a GP, you first of all have to go and see a link worker. So self-referral is something that I think people are very interested in, and some social prescribing schemes already allow self-referral, so you don't have to see the doctor first. You can just book to see the link worker. And eventually, we would want to probably open up referral to link workers from a wide range of professionals, not just within the health settings, but social workers, children's centre workers, school parent liaison officers, community centre workers. We feel that eventually all of these people should be able to refer people to link workers as well. So that link workers start to get seen really as community workers who are there in the community to support people with their lives.
Great, thank you. I hope that answered your questions, Nikki. There was another question from Anjali who is asking, are there specific activities for healthy weight maintenance?
Yes, there are, and we've run very successful weight management programs at Bromley by Bow over the years, commissioned by our local authorities' public health team. There are, very well documented programs of how to support people to lose weight. The truth of the matter is losing weight is tremendously difficult. And it's, as far as I understand the science, it's about 80% is around food and about 20% is around physical activity in terms of where you need to put your emphasis to lose weight. It requires huge amounts of support and motivation as well, and willpower. And whilst undoubtedly, as I understand it from the experts, it's relatively easy to get people to lose weight, keeping that weight off is much, much harder. And I think the truth of the matter is that weight management programs have limited success in the long term. Perhaps the really most important thing is how do we help people to not put the weight on in the first place. I don't know if you know this, but in Britain at the moment, we're amongst one of the most obese nations in the world, but 66%, fully 2 out of every 3 adults in Britain is either overweight or obese at the moment. And that number creeps up year on year. And the health challenges that come with that are absolutely phenomenal. Type 2 diabetes is very, very closely related to obesity. If you talk to GPs in deprived communities now, it is not unusual to see people in their 20s presenting with type 2 diabetes, something that would have been virtually unheard of 30 years ago. And if you look at the long-term rates of diabetes, they have just began to creep up in the 1970s and have gone on going up ever since, very much linked to the curve of obesity as well. And we need really to tackle what's called the obesogenic environment. Is probably that requires public health interventions around food and eating and so on, and exercise in a much more population way than just simply working with the individuals who are overweight. But there are some successful programs. There's a wonderful program that was invented in Scotland called the Mile a Day program for children in schools, to run a mile every day in school, for example. And there are some really stunning community approaches to walking buses, for example, getting children to be walked to school rather than being driven to school, and so on. And, our habits have changed drastically in the last 30 or 40 years. If you actually, a friend of my parents did a study on this, and I think it was 40 years ago now, but 40 years ago, sort of 10 or 15% of children were driven to school, and 85% of children walked to school. And then you went, this is primary school, and then you went sort of 30 years later, and those percentages completely flipped the other way. So 85% were being driven to school, and 15% were walking to school. And it's remarkable the speed with which the habits in our communities have changed so drastically. One of the real challenges is the rise of what's called ultra-processed food. Britain, so there are 4 categories of food. This is developed by a Brazilian nutritionalist. The 4th category, the highest level of processing, is called ultra-processed food. And over 50% of food eaten in British homes, this isn't takeaway food, this is food eaten in British homes. This is in the category of ultra-processed food. It's remarkably different to nations like Greece and Italy and France, where that percentage is about 13% or 15%. So we need to do something very critical about our culinary habits in Britain, actually. Yeah.
Thanks, Dan. We have, I think that can be our last question. Very interesting question. Why do you think the Bromley by Bow model isn't one that is currently adopted nationally? And what do we need to do to get to that point?
Great. Well, okay, so there was a movement of healthy living centres, it has to be said. Bromley by Bow, as I mentioned previously, was the first and one of the flagships of that movement in the late 1990s and early thousands. That movement didn't flourish, and partly because there was no long-term government funding for the 350 or so healthy living centres that were developed. It has to be said, most of those healthy living centres didn't look anything like Bromley by Bow, and I think most of them, very few of them, actually incorporated primary care as part of their model. And sustaining Bromley by Bow, as I say, is the work of its staff of 100 staff, and then its health partner staff as well on top of that. And it has to be said, it requires a lot of funding to keep this model going year on year. So it's not an easy task, it has to be said. So why haven't the messages from Bromley by Bow travelled? Well, I think probably that's a bit like asking the question, why did the dinosaurs die out? To which the answer, of course, is if you look around you, all of the birds that you see in your back garden or in the street are actually they're the dinosaurs who are still with us today. So Bromley by Bow, its messages have travelled actually. And I think that one would argue that the adoption by NHS England of social prescribing 3 years ago is very much the adoption of an element of the Bromley by Bow model. This idea that clinicians should understand the social determinants of health of their patients and refer them to these wonderful people called social prescribing link workers, and then onward to community provision that's devised and developed by communities. So there's an element of Bromley by Bow that certainly has now become enshrined in national policy. Why don't we have more community or health and well-being hubs that look like Bromley by Bow? And that is a really good question. I think there are some huge structural challenges to that. But having said that, we are now working on 2 or 3 live projects in London and the southeast of England that aspire to become Bromley, using new build projects that aspire to become Bromley by Bow like health and wellbeing hubs that we hope will be built in the next sort of 2 to 5 years. There was one built in Manchester, in Trafford in Manchester 3 years ago, which was opened 3 years ago, which was modelled on Bromley by Bow, and it's very, very successful. It's called Limelight, and you can look it up. And it's a kind of modern day version of Bromley by Bow as well. There is actually still a thriving healthy living centre movement in Scotland and Northern Ireland, interestingly, even if there isn't in England. So that's also interesting. They retained their healthy living centre movement as well. But I think that the sort of, whatever that figure is, 10,000 or so visitors who've come on the Knowledge Share programme in the last 7 or 8 years to Bromley by Bow absolutely speaks to this zeitgeist of a realization that the biomedical model of health has completely run out of road and that the future has to be something different. When all of these sort of health systems were developed in developed countries, sort of after the Second World War, they were very much premised on the idea of people having short episodes of ill health interspersed by very long periods of good health. Of course, the rise of long-term health conditions, and it has to be said, the increase in life expectancy, means that people are living with significant long-term health conditions for 20, 25 years, and sometimes considerably longer. Much of it driven by the social determinants of health, by poverty, by poor employment, by poor housing, and all sorts of, and so on. So if we think about, to mention 3 of the things we've just talked about on today's call: diabetes, obesity, and mental health. It doesn't take a genius to work out that those conditions are entirely unsusceptible to the effects, or very little susceptible to the effects, of 10-minute consultations in small GP consulting rooms once every few months. That's not going to get people to lose weight. It's not going to get people to manage their diabetes well, and it won't improve their mental health substantially. We need very, very different responses to the modern pandemics of loneliness, of inactivity, of obesity and diabetes and mental health and so on. So I think there is a growing realization amongst those involved in clinical health and clinical health systems around the world that new solutions are needed, which I think is why Bromley by Bow receives 1,500 visitors a year who come to look at this model. But there are very, very strong structural barriers to how health systems are financed, to how to bring together the money from health systems with other money to create these kind of multidisciplinary community hubs. One of the big challenges in Britain is that, of course, general practices are, GPs are private businesses. One of the features of the 1948 NHS settlement is that GPs are private businesses and mainly own their own premises. So trying to build things like Bromley by Bow requires a new model of ownership of premises, a new model of who's prepared therefore to pay for those premises, and a new model of, and particularly if you want the community to be involved in the ownership and running of those premises as well. So that requires new structures, and it requires funding to be put into those new structures as well, that sits outside the current model of funding community provision. But it also requires leaps of faith, which is where I go back to Einstein's law of insanity, really. We can go on working with deprived communities in the same way that we've been working for the last 40, 50, 60 years. And the result is that we go on having disempowered, deprived communities. Or we can think about doing things differently. And that requires a leap of faith. And Bromley by Bow, if you like, is a leap of faith. And Bromley by Bow, every morning when people like Berenice and myself come to work at Bromley by Bow, it's that faith in what we're, and our GPs come to Bromley by Bow and our welfare advisors come into Bromley by Bow every morning. It's that leap of faith that with our community, we can construct solutions, and it's about the process as much as the product that's important. It's about the daily living of the Bromley by Bow experience for our community that is that leap of faith and that act of hope towards the future. And that, I think, is quite difficult for statutory systems who, you know, if they're going to invest £4 or £5 million, they want to see a plan where every I is dotted and every T is crossed, not just now, but for the next 30 years. And community isn't really like that. Community is built day on day, week on week, and you don't know what it's going to be like in 3 years' time. But these governmental or local authority or health plans kind of want some guarantee of success in 30 years' time. But nobody can give that guarantee of success. But on the opposite side, we can see the failures of the past. They're all around us. So we need to have courage and we need to have faith that we, with our communities, can construct the new models that will empower our communities towards better health and well-being.
Thanks, Dan. Alex, feel free to ask.
It was only quick, and it's not a new question. It was just to bounce off of what Dan was saying. Thank you. I'm so thankful for this. It's really helped me. Like, this is what. Yes, I remember it all now. It's been a few years since I last visited Bromley by Bow, so it's good. It's good. It was just coming off of that what you were saying about the bringing together the different finances from health. I know that Dorset is one of the new piloting the integrated care system. So do you see that as, instead of the CCG, do you see that as a way of overcoming that difficulty in pulling things together, the finances?
At least in principle, yes, because ICSs are like mini health systems. They're intended to have a population of at least 1 million and in some cases up to about 3 million people. So they bring together primary care and secondary care. So you create one single health budget. And they're meant to also have substantial local authority involvement and indeed voluntary sector involvement as well. The truth is that some ICSs have done that well and others are still on kind of, you know, it's very early days for them, it has to be said. Mm-hmm. And some of them haven't really quite fully involved. So they're still very health focused and there's far less involvement of the local authority and probably very little of the voluntary sector yet. But their premise is that this should be a sort of tripartite piece of work, voluntary sector, local authority and health, and that they should be working together. And you might argue, and with the community as well. I mean, the voluntary sector can't be taken as proxy for the community, there's the community as well. So I think there's some hope there. And they're in their infancy at the moment. I think it's up for all of us to help to try to shape ICSs and try to move the whole thing into a much more preventative space than a curative health space, as it were, and try to create pooling of budgets that allow that to happen. So yes, I think ICSs definitely provide an opportunity for us to work at a level of scale that is probably more manageable, although they're still quite large. You know, they're you know, as I say, I think between 1 and 3 million people, probably most ICSs. Of course, below that there is and so they create one set of geography. Below that sits the borough geographies, which is smaller. So the ICSs have to relate to the individual boroughs within their geography as well. And then below that, of course, sit the primary care networks, which is becoming, in a sense, the fundamental basic building block of the NHS. And that's probably really important, particularly for people like yourself in terms of how you relate to the primary care networks, who will be the people who will employ the social prescribing link workers, for example, as well. But yes, I think ICS is heralding new opportunity. Yeah.
Brilliant, thank you.
Yeah.
That's great. Thank you very much, everyone. So we're coming to the end of this session. So I've put a few links in the chat box, but we'll send you a follow-up email with some useful links to future events as well. And the recording of this session, so that will be available for a week after today. And yeah, if you want to keep in touch, we run bespoke workshops as well for teams that would wish to, exchange knowledge and learn a few things about specific areas of the center. So do keep in touch. I've put the email address as well in there. So yeah, we'll be glad to hear from you. And yeah, I think that's pretty much it for today. And hopefully this session was interesting to you and kind of inspired you for your everyday work. Yeah, so hopefully see you soon at another event.
Yeah, thank you. It's been great to have you with us. And as Berenice said, do stay in touch. And if there's any way we can help you in the future, please do let us know. Yeah.
Thank you, everyone. Bye.
Bye.